Dr. Narendranathan from the Kerala chapter of the Indian Society of Gastroenterology, coming to you with a session on clinical epidemiology and biostatistics. In this session, we'll discuss risk and risk factors and how to measure risk. Before going into the details, let us see how do we define risk and risk factors. Risk refers to the probability of an untoward event, and risk factor is a variable that increases the chance of a person developing a disease. The risk factors can be classified into two: modifiable risk factors and non-modifiable risk factors. Modifiable risk factors are alcoholism, smoking, overweight, hypercholesterolemia, etc. We can modify these risk factors, like we can we can stop alcoholism, treat hypercholesterolemia, and so on and so forth. But non-modifiable risk factors are beyond our control, like age, gender, the family history, genotype. These are non-modifiable risk factors. Now let's go into one of the study designs used to examine risk and risk factors is case control study. In the case control study, what we do is that we take a group of cases and controls. It may be persons with cirrhosis of the liver, where we're looking at alcohol as a risk factor. When you take a group of persons with cirrhosis and a group of persons without cirrhosis, what we do is that we look for the risk factor. That is, how many of them had taken alcohol, or how many of them had the risk factor. So here we find that about 50% of the persons with the cirrhosis had taken alcohol, whereas only 1/3 of the controls had taken alcohol. So in the cases and the control, we look for the risk factor, we compare the two groups, and we express our result as an odds ratio. Let's see in detail what is an odds ratio by taking a published study. In this study, Sekin et al., which was published in Gastroenterology Research and Practice, they are looking at Helicobacter pylori in persons with and without duodenal ulcer. They found that the antral biopsy of persons with duodenal ulcer contained 75% of these people had Helicobacter pylori, and in those without duodenal ulcer, only 50% had Helicobacter pylori. Now look at what are the odds of persons having Helicobacter pylori. Odds, by definition, is probability divided by 1 minus probability. So these people, 75% means the probability is 0.75. 1 minus probability is 0.25. Similarly, here the probability is 0.5. 1 minus probability is again 0.5. So the odds of H. pylori in duodenal ulcer is 0.75 divided by 0.25 is equal to 3. And in those without duodenal ulcer, it is 0.5 divided by 0.5 is equal to 1. So the ratio between two odds is what is called as an odds ratio. And in this group, 3 divided 1, the odds ratio is 3. Now let us take an example of the other study design used to evaluate risk and risk factors. These are called the cohort studies. This, what we do is assemble persons with and without the risk factor, and then we follow them for a period of time. Let's say we have persons with risk factor, follow them up and look for the disease. It may be people with smoking, we follow them and look for cancer. Or people who are chewing, follow them up, look for oral cancer. People with obesity and see how many of them develop fatty liver. You take persons with and without risk factor, follow them up for a period of time, and see how many of them develop the disease in the two groups. And we compare the two groups, and what we get, and the result is expressed as a relative risk. Now, taking an example, the fatty liver in obesity, let's assume
that 100 obese persons were followed for 5 years, and they developed 50% of them developed fatty liver at the end of 5 years. So the risk of developing fatty liver and obesity is 50 divided by 100 is 0.5. In persons without fatty liver, the 100 without obesity, 100 non-obese persons followed for 5 years, fatty liver occurred in 20%. So the risk of fatty liver in persons who are not obese is 0.2. So the relative risk is calculated by 0.5 divided by 0.2 is equal to 2.5. That's why it reached the relative risk from a cohort study in which we follow this patient's prospectively. We have discussed about odds ratio, relative risk, and let us see now what is hazard ratio. As you can see in this figure, there are two lines. One line represents patients with severe COVID without diabetes, and the other one is patients with diabetes. This actually shows the survival probabilities, the survival of these persons when they are followed up for about 30 days. And these types of curve, which shows the survival probability over a period of time, are called as survival curves. And they were described by two statisticians, Kaplan and Mayo. And what we see here is that when they were being followed, when it started, there was one, the survival rate is 1 because no one has died. But as we follow these people over a period of time, we see that some people die, and so that the line drops down. And as you can see, in person, after about 12 days, we find that in persons with diabetes, only about 30 to 34% have survived. 16 out of 48% have survived. Whereas when it comes to the persons without diabetes, it's about 64 to 65% have survived. So what this curve shows is the rate, the mortality rate in the two groups, or the mortality. We do not usually, now every survival curve does not look at mortality. It looks at the time to event. It may be the time for a person with fatty liver to develop cirrhosis, or the time for a person with cirrhosis to develop liver cancer, and so on. It's only a time to event. So when an event occurs, this is what is called as hazard rate. Here, the hazard is the mortality. So the hazard rate in the two groups are compared, and we get what is called as a hazard ratio. So in this study, we find that the hazard ratio is 3.17. So there is a 3 times greater chance that a person with diabetes the mortality will be 3 times higher in persons with diabetes compared to non-diabetes. Let us now examine the odds ratio, the point estimates, and the confidence interval with the help of an odds ratio diagram. Here we find a line at 1, which is the line of no effect. So let us see about 3 exposures. Here we find an exposure with a confidence interval, which is the upper limit is below 1, which means that the exposure is lower in the group compared to the controls, in the study group compared to the controls. Let's take an example. The odds ratio of smoking in ulcerative colitis is 0.8 with the confidence interval 0.4 to 0.99. The upper limit is below 1, which means that smoking is a protective for ulcerative colitis. When the upper limit of the confidence interval is below 1, we know that the p-value will be less than 0.05. Let's take another example, this time a risk factor. We know that the lower limit of the confidence interval is above 1, and this is alcohol and carcinoma of pharynx. The odds ratio is 12 with a range of 4 to 32. And here also we know that the p-value will be less than 0.05. Let's take another example. For example, the Helicobacter pylori in coronary artery disease. The odds ratio is 2, but we find that the confidence interval overlaps 1 with the lower limit of confidence interval is overlapping 1. It's 0.5 to 12. So this is not a risk factor. And here the p-value will be definitely above 0.05. Now let us see the phenomenon called dose response analysis. We know that BMI is a significant risk factor for fatty liver disease. What happens when the BMI increases 23, 24, 20, and it goes up? What happens to the odds ratio? As you can see here, that as the BMI increases, the odds ratio also increases. The odds ratio also increases as the BMI increases. Same thing with women also. As the BMI increases, the odds ratio for development of fatty liver also increases. This is what we call as a dose response phenomenon, dose response. What happens when there are multiple risk factors? Take the example of the combined effects of diastolic blood pressure and serum cholesterol. This figure shows the serum cholesterol in the x-axis. As the serum cholesterol increases, we find that the chance of a person developing coronary artery disease also increases. But when we see that the chance of developing a coronary artery disease with a cholesterol of 4.7 millimole, with a blood pressure of 70, below 76, diastolic blood pressure below 76 is about 4 per 10,000. But when it increases, let us say that when it increases, when the cholesterol level increases to 6.3, see that the risk the increases to 10 per 10,000. Similarly, as the cholesterol level increases, the risk factor also increases, and it increases further when the blood pressure increases. This effect of when one risk factor positively modifies the effect of the other, we call it as effect modification. Discuss another important topic, that's confounding. You know that when you are, let us take a highly hypothetical example of the association between ice cubes and intoxication. We know that many persons take beverages with ice cubes in it, and you may also find that many of them get intoxicated. If you conduct an analysis purely between ice cubes and intoxication, you may find that ice cubes is a significant predictor of intoxication. But we know that this is because of the effect of alcohol, which is associated both with the ice cubes, because many people take alcoholic drinks with ice cubes, and also alcohol can produce intoxication. These types of variables are what are called as the confounding variable. Confounding is the distortion of the association between an exposure and an outcome by an extraneous third variable called a confounder. So if you are looking at intoxication and ice cubes causing intoxication alone, we may reach a wrong conclusion that ice cubes may produce intoxication because of the confounding variable. And you can eliminate this by conducting an adjusted analysis by examining the effect of ice cubes after adjusting for alcohol. Then we can find out confounding. Another example of confounding is looking at obesity and coronary artery disease. We know that obesity may be associated with other variables like cholesterol, diabetes, high blood pressure. And these three variables may be associated with obesity, and they're also associated with coronary artery disease. So if you are looking just at obesity and coronary artery disease, you may think that obesity is a risk factor for a coronary artery disease if you don't take into account the confounding variables. So if you are looking at, does obesity increase the risk of coronary artery disease independently of cholesterol, hypertension, and diabetes? So if you are to look at the association with obesity and coronary artery disease,
You can find it out only if you exclude the effect of confounding variables like cholesterol, diabetes, and high blood pressure. Finally, we come to the discussion on the importance of study of risk. Every clinician-patient interaction, for every interaction, a knowledge of risk is important, not only in making a diagnosis and suggesting treatment, but also to discuss about the prognosis and methods of prevention. Let us look at a few of these things. First is about prediction. For prediction, what we follow what is called the risk stratification. So every patient with cirrhosis is not the same. They respond differently to, their outcome is different for surgeries, different after bleed, after acute hepatitis, they all respond differently. Similarly, a person with fatty liver disease is not the same. Every patient is not the same. Some has no fibrosis, some have a significant amount of inflammation. So people vary. And the treatment and our approach will also vary depending upon the condition. And this, we do this by what is called as a risk stratification. Let's take the classical example of chronic liver disease, where we have the MELD score or model for end-stage liver disease score. So this gives us the persons with MELD score, different MELD score, and what is the outcome of surgery, a major surgery, or outcome of a major GI bleed, or outcome after an acute alcoholic hepatitis. If the score is below 9, we know that the mortality is around 1.9%. It increases to 6 when the score increases 10 to 19, and so on and so forth. So when it comes more than 40, the mortality is about 71.3%. This is one of the importance of risk stratification, in which we accept that one size fits all approach is not going to work in clinical medicine, and that people refer, and you can stratify them based on their risk too. The next is diagnosis. Especially in screening, we know that we can improve the diagnostic tests by increasing their positive predictive value in doing the test in persons at risk of getting a disease. So we choose people to whom we do a breast cancer screening or carcinoma colon screening or ischemic heart disease screening. And so for diagnosis, as knowledge of risk helps us. And then prevention. You may all know about the famous study of John Snow, the famous epidemiologist, who found out that a cholera outbreak occurred in people, and the risk factor was taking water from a particular tap, particular source. And when an access to that water source was prevented, the cholera was denied, the cholera could be prevented. So a study of risk helps us in prevention. Finally, in treatment, you know that when a person with fatty liver comes to you, we know that we have to take care of other risk factors like diabetes, obesity, hypertriglyceridemia, and these things occur for patients. So this, in a nutshell, is the importance of the study of risk. I'd like to end here and thank you all for listening to this presentation. And I would like to get your feedbacks. Please give us your feedback. And it is your feedback which makes us, which improves these types of presentation. Thank you once again. Thank you.